Good evening, all. I welcome you all to the free webinar on International Women's Cancer Awareness Day, organized by International Association of Oncology and scientific partner BioLeaks Worldwide. Starting with today's session, I would like to quote a few lines of Stuart Scott. You beat cancer by how you live, why you live, and in the manner in which you live. As a non-profit organization, BioLeaks Worldwide is a globally recognized professional association that operates under the Techno-Array Group. It serves to propel and fuel all innovative works of research with immense potential in the field of healthcare, life sciences, pharmaceutical sciences, and the medical sciences in general. In this capacity, BioLeaks Worldwide has been directly responsible for a significant amount of the revolutionary developments that have taken place in these fields over the past few decades. Talking about our organizers, International Association of Oncology is one of the world's leading professional associations for medical oncology and life science professionals caring for people. International Association of Oncology is a non-profitable professional association meant for research and development in the field of medical oncology and life science. International Association of Oncology, or IAO, is an international forum for researchers, academicians, doctors, and practitioners for sharing knowledge and innovation in the field of healthcare and life sciences. IAO aims to bring together worldwide researchers and professionals, encourage intellectual development, and providing opportunities for networking and collaboration. IAO delivers access to its members, the industry's most essential technical information, by organizing conferences, workshops, annual convention meetings, and provides networking opportunities both locally and globally. Members have the ability to stay current in their chosen profession, connect with peers, and invest in their future. IAO also provides a broad-based home for members and societies who are interested in aspects of the medical oncology and life sciences, together with companies, hospitals, government organizations, pharmaceutical company researchers, and university researchers. I welcome you all again for today's session. Moving ahead, I would like to welcome all the dignitaries over here to give a keynote speech. I would first like to call Dr. Manjula Rao. I would like to welcome her. She is currently working as a consultant breast cancer specialist and oncoplastic surgeon, Apollo Proton Cancer Center, Chennai, Tamil Nadu, India. Welcome, ma'am. I would like to welcome you to say a few words on today's session.
Thank you so much, Amna. Thank you for that introduction. Hello, everyone. At the outset,
sorry for the interrupt, ma'am. I would like to Dr. Vishwas, our IOA president, for the introduction. Sorry
sure.
For the introduction, ma'am.
No problem.
I would like to introduce our IOA president, Dr. Ghanshyam Biswat, sir. Over to you, sir.
Yeah, thank you, Amna. Thank you, Kanchan. So, good evening, everybody. So today is a International Women's Day, and I see four of our key speakers are super women, super moms, and they are great in their field. So I personally know Professor Dr. Anita. So she has been a great colleague and an elder sister to me. So I'm a medical oncologist. So in oncology for last more than 2 decades now. So I think in regards to breast cancer, so there has been a lot of changes, especially in last 2 decades. So if you see the incidence of cancer, so now the breast cancer has become the #1. So it has in fact surpassed lung cancer in regards to global incidence. That was in 2020 Globocan. And we know that 2/3 of these cancers, breast and cervical cancers, so in women, so that constitutes the biggest chunk. So especially in regards to breast cancer, so there has been the change in the understanding of the disease and in regards to diagnosis. And today we see a 0.5 centimeter tumor. So because of awareness, because of screening modalities, so which was not seen before, so probably during our DM days or early 2000. So in regards to the surgery, there has been a phenomenal changes looking at so breast conservation versus mastectomy. So whether to address axilla or not. In regards to medical treatment, today, not every patients are entertained with chemotherapy. There are many patients who will go away with only a hormonal treatments, and that's around 15 to 20% of the patients who are low risk. There are many patients who will be a candidate for immunotherapy and targeted therapy, which Dr. Anita will definitely speak on. So I think so today breast cancer is a heterogeneous group. We need to identify this disease early. So we understand that many may not have a risk factor, but this disease is common in a postmenopausal, but unfortunately, we are seeing a quarter of patients, even less than 35, so which is a cancer in the young. So one of our keynote speaker will address on that. So I think so those are the areas and the triple negative areas and the patients who present de novo with a brain metastasis. So these are a concern at this moment. So ladies and gentlemen, so for next 3 hours, so we'll learn from our esteemed keynote speakers. So what's happening in the field of breast cancer, and lastly, we'll have a talk in the cervical cancer too. Thank you so much.
Thank you so much, Dr. Ghanshyam. I'm really sorry for the mishap that happened, but sir, thank you for your lovely words. And to introduce you, sir, Dr. Ghanshyam Biswas is the Executive Director, Sparsh Hospital and Critical Care, Bhubaneswar, Odisha, India. So we are really honored to have you on board with us for today's webinar. Thank you for joining us, sir. Moving ahead with today's session, I would like to welcome our next speaker, Dr. Manjula Rao. She is currently working as a consultant breast cancer specialist and oncoplastic surgeon, Apollo Proton Cancer Center, Chennai, Tamil Nadu, India. I welcome you, ma'am.
Thank you. Thank you once again, Amna, for that introduction. Greetings to Dr. Ghanshyam Biswas as well. It was very nice, sir, to hear your introduction. He, sir, has given a fantastic outline of the situation that our country also is in currently with regards to breast cancer specifically. Now, at the outset, I'd really like to thank the organizers and IAO specifically for including me in this August list of keynote speakers today. It's such an honor for me, and happy Women's Day, everyone. So I'd like to begin. I'm going to share my screen. Just give me 2 minutes, please. Okay, is it visible now?
Yes, ma'am, it's visible.
Okay, just bear with me another moment. I will just... Okay, great. So I will be talking about oligometastasis. This is a topic that I'm specifically interested in because this offers us hope. It is a silver lining in an otherwise almost hopeless scenario that is stage 4 breast cancer. Okay, for some reason it's not moving. Just a second. I just apologize. Just give me 2 minutes. I'm having some issues. Okay, fine. So I have no disclosures. I'm not able to change my slides. I'm not sure why. Okay, fine. All right. Sorry, am I audible? Hello?
Yes, ma'am.
Yeah, okay. I really apologize for this. So oligometastasis is what I'm going to be talking about today. I'm going to begin with giving you an outline of what we generally do in stage 4 breast cancer, metastatic breast cancer to begin with. So the standard of care for stage 4 breast cancer has for the longest time been systemic therapy, wherein surgery of the primary is reserved to palliation of the symptomatic breast lesions, and even locoregional treatment in the form of radiotherapy has been reserved for palliation of symptomatic breast lesions, mainly to improve the quality of life of the patient. Clinical practice, however, has been varied because there are a lot of clinicians who are so worried about the uncontrollable progression of the local disease, and which may impact and reduce a patient's quality of life, which is why, while on one hand, the standard of care is systemic therapy, there are a lot of other clinicians who actually go ahead and even operate on the primary in stage 4 breast cancer. Now, we are going to look at the evidence, discussing the pros and cons of this. So now, why has the interest in surgery of primary and metastatic breast cancer arisen? That's mainly because experiments on animal models have shown that removal of the primary tumor may in fact restore the immunocompetence in patients and hence improve their response to treatment. And of course, there's the theory of tumor debulking, which renders systemic therapy more effective. It reduces the emergence of chemo-resistant cells and removes the necrotic cells. It allows better immunomodulation and decreases the potential of metastasis. And we have evidence of survival benefits of debulking surgery from other solid organ tumors as well. And there are a lot of retrospective reviews which give evidence of the benefit of locoregional therapy in metastatic breast cancer. So these are the few reviews which have actually outlined that primary treatment or surgery of the primary in metastatic breast cancer may actually be better and have better outcomes for the patient. However, one common vein that is running through all these studies is that all these retrospective studies have been conducted in an uncontrolled manner. So there is a very obvious selection bias. Obviously, the patients who were offered surgery of the primary had better median survival, and they also belong to a group of better biology. So, younger patients, ER positive, HER2 negative tumors, and a lower metastatic disease burden. So these patients obviously did much better. And while you have all this evidence from retrospective reviews that sort of laud surgery of the primary, support surgery of the primary in metastatic breast cancer, here is a very, I would call it a landmark paper by Fisher again, wherein, they looked at mouse models. And this experiment showed that removal of the primary tumor may actually cause the distant metastasis to proliferate or grow due to an interplay between the various growth factors. So certain growth factors which were otherwise indolent, they would become active when the primary tumor was removed, and they would cause the metastasis to proliferate or grow. And this theory has now been proven in multiple randomized control trials that have been done. As you can see, the first paper is one done at Tata Memorial Hospital, an open label randomized control trial, wherein they demonstrated the same. They showed no benefit of locoregional treatment in metastatic breast cancer. And similarly, you have results from the ABCG28 positive trial, and the ECOG Akron results are awaited. Now you have this paper by Soren's group from Turkey, wherein this particular randomized trial, it actually showed that patients in the loco-regional treatment group, they had a 5-year overall survival of 41.6% versus those who underwent only systemic therapy. So this is one paper, which is an outlier, which actually showed benefit of surgery of the primary. However, if you look at the patient population in this study, the patients in the loco-regional treatment group, they had higher number of ER/PR positive tumors, lower number of triple negative tumors, and most of these patients had bone-only metastasis. So again, if you see, they have actually looked at a group which even otherwise biologically are known to do very well, and they have included them in the loco-regional treatment group. So there is a selection bias that comes into play in this study as well, which makes us debate as to what came first, the chicken or the egg. Did these patients do better because they had surgery of the primary, or would they have done better anyhow, even without surgery, because their biology was so good? Which brings us to the point that when determining treatment for patients with breast cancer, it is very important to select the patient accordingly. So personalization of treatment is very, very important. Now, while all this debate about metastatic breast cancer was ongoing, as early as 1995, you have two researchers, Hellman and Weisselbaum, who proposed or coined the term oligometastasis. So this was, they described oligometastasis. It was an extension of the spectrum theory that was coined, and they described it as an intermediate state between local progression and full-blown metastasis. So oligometastasis is a condition of limited metastatic capacity, and the implication of description of this particular state was that they believed that this was one condition wherein we could control or resect the primary tumor and ablate the metastatic site as well, either with surgery or radiation therapy. There was a possibility of offering even patients with stage 4 disease possibility of prolonged disease-free survival or even cure. So they proposed an aggressive multidisciplinary approach in those patients who belonged to this particular group. This is a very nice representation from Reyes DK et al.'s paper, wherein they show how oligometastatic disease is basically a condition where the tumor cells have not yet developed the capacity to go and establish a colony in the distant organ site, whereas a full-blown metastatic breast cancer, the cells have already gotten that ability, and the microenvironment of the host organ or the distant site has been primed for that metastatic cell to come and form a colony. So how do we define oligometastasis? There is no strict definition. There are different studies who have proposed different definitions. Some studies have proposed looking at less than or equal to 3 sites, some of them 5 sites. But having said that, you even have studies that are looking at loco-regional treatment in patients with 10 sites. So how exactly do you define it? So metastatic disease that is limited in total disease burden, usually by the number of clinically evident or radiographic sites, not rapidly spreading to more sites, and one which can be controlled by adequate loco-regional therapy as well as treatment of the distant site so as not to impair the quality of life of the patient. Now, Paget had proposed this very interesting seed and soil theory, which is very relevant even today. What he believed was that metastasis as such is not a very random process. You just don't have cells jumping from one place to one organ and settling down there. He believed that this whole process was driven entirely by the circulator, and there was an interaction that occurred between the tumor cell and the target organ. he believed that for the tumor cell or for the seed to go and deposit, the soil had to be apt. For it to go and deposit and actually germinate and grow in the distant site, you had to have good soil. So the microenvironment had to be apt for the tumor cell to come, deposit, and grow. So what he said was this was driven by the tumor microenvironment and host-derived cells that promote tumor growth and suppress host immunity. Now, this is a lovely paper that I came across by Gupta et al. In the Cell Journal. So it's called Cancer Metastasis Building a Framework, wherein they've actually described the factors in a tumor's microenvironment that limits tumor progression. So you have chemical barriers, physical barriers, and the biological barriers that have been mentioned in this diagram here, which actually limit the progression of a tumor to a distant site. However, if the tumor has actually crossed all these barriers and managed to spread to a distant site and deposit, it is governed by the behavior or nature of the tumor, how aggressive it is, how indolent it is, and that determines its ability to metastasize. So this is the paper that I mentioned. The diagram in the previous slide was also from the same paper. And again, they have outlined the various steps that cell goes through when it is attempting to metastasize. And a shortfall in any one of these steps can halt the metastasis process. So this entire thing is governed not just by the ability of the tumor, but also by the vascularity, also by the tumor, the host microenvironment, and also by certain organ-specific metastasis factors and functions. So a lot of these processes are actually governed by genes. There are genes that play a role in, initiating metastasis, for the metastasis to progress, spread widespread. Which organ can the cancer cell metastasize to? That also has a genetic basis. In fact, the number of metastases that may develop is also governed by genes. So a break in any one of these defense systems that we've discussed about results in genetic instability of the tumor cells, hence increasing its metastatic potential. Now let's just looking at some statistics, okay? The incidence of oligometastatic breast cancer is very, very small. It's 12 to 18% of all the metastatic breast cancers, which itself is 5 to 7% of the total number of breast cancer cases. And we have now the evidence for treatment of oligometastatic breast cancer is mostly from retrospective reviews. We don't have evidence we don't have a lot of randomized controlled trials. We don't have very good quality evidence. And a lot of these trials that we've derived this evidence from is not restricted to only breast cancer. It encompasses oligometastasis from different primaries because the incidence of OMBC is that less. So this is a paper by Pastorino et al. Very, very relevant results. They looked at performing lung metastatectomy in patients. They looked at various primaries: breast, colorectal, prostate, etc. And this paper showed that those patients who achieved a complete resection of their lung metastasis in terms of clear margins and everything, the 5-year overall survival was much higher. It was 36% than what could have been expected or what was the norm in metastatic breast cancers at the time. But this improved survival was completely dependent on the kind of patient selected. It was determined by the size of the tumor primary, by the number of metastatic sites, and also by the surgical margins that were achieved. So those with fewer mets, clear margins, good biology, longer disease-free survival, they fared better, wherein the 10-year overall survival reached up to almost 40%. Now, this is another paper by Jane et al., wherein they actually looked at the concept of oligorecurrence. So patients with stage 2, 1 to 3 breast cancer who were treated between 1978 to 2005, they looked at those patients with first failure, right? And patients with less than or equal to 5 mets were labeled as oligometastatic and more than 5 mets as polymets. So in this, it showed that the median overall survival after first failure was almost 4 years in patients with oligometastasis, whereas those with full-blown metastasis, they didn't do that well. The 5-year overall survival was also much higher in the oligometastatic group compared to the polymetastatic group, which is why they concluded that it was very obvious that patients with oligometastasis would do biologically better, and they may benefit from aggressive locoregional therapy. Now, looking at some randomized evidence that we have now. So this is a phase 2 randomized clinical trial, wherein both of these trials, actually, they looked at non-small cell lung cancer. And both the trials were actually stopped prematurely because the ablative treatments, they looked at basically radiotherapy of the distant sites, and this achieved a 3-fold improvement in the progression-free survival in these patients. Similarly, you have results of the EORTC 40004 trial that was done for patients with oligometastatic colorectal liver mets. This was a phase 2 study and was the first randomized controlled trial wherein they showed the efficacy of RFA. And this patient as well, the initial results, though it showed no difference in the overall survival in both the arms, but the 8-year overall survival was much higher in the RFA arm versus only 9% in the systemic treatment arm. Now we have some trials that are undergoing that are looking at oligometastatic cancers in breast. So this is a Sabre Comet trial wherein they've looked at oligometastatic cancers, but again, it's not restricted only to breast cancers. They've also looked at colorectal, lung, etc. And even this trial, the results, they showed superior overall survival in the arm that underwent systemic therapy as well as Sabre. Though the second arm wherein they underwent ablative radiotherapy, it was associated with a slightly more number of adverse effects, but the overall quality of life was unaffected. Now, this is a very interesting trial, the Sabre Comet 10 trial, wherein they're actually looking at Sabre, that is stereotactic ablative radiotherapy, for treatment of almost 4 to 10 oligometastatic tumors. And this is a phase 3 trial. So we have to look at the results of this trial and see what they come up with. Now, there's one more trial which we're eagerly awaiting the results of, the Gnrh BR002 trial. This is a phase 2/phase 3 trial of standard treatment, that is systemic treatment with or without SBRT, and or surgical ablation for newly oligometastatic breast cancer only. So this trial, they're looking at progression-free survival first, and then if the results are encouraging, the secondary outcomes, they want to look at the 5-year overall survival. So looking at all this evidence, we don't have a lot of randomized control trial evidence as yet, but of course, things look promising at the moment, wherein we do know one thing, that breast cancer treatment, the one rule is that biology is king. So no matter if we are treating, say, a very aggressive triple negative breast cancer, and we are running a race against the pace of a particularly aggressive tumor, we must remember that we are fighting a losing battle, because at the end of the day, biology is king. So patient selection is very important. It's important for us to filter out that group of patients who are truly oligometastatic. So we give them systemic therapy. They have been stable on systemic therapy for say 6 months to a year, and then we can consider treatment of the primary and include ablation of the metastatic site as well. But the whole concept of treating oligometastatic patients aggressively with a curative intent is that we must look at survival. So if we are looking at survival and they have to do well, we have to ensure that their survivorship is not affected. And hence we should ensure that in attempting to treat them aggressively, we don't impair their quality of life. Now, the way ahead, we still have a lot to understand about oligometastatic disease. We need to find out how to filter out that group of patients who will benefit from aggressive treatment with curative intent despite the number of meds. We need to understand what are the limits, how many meds can we actually consider to be oligometastatic. What about those patients who with oligorecurrence, so who are treated completely and then they develop one or two mets which come under the criteria of oligometastasis? Or what if one patient whose disease is under control, but then they progress in only one or two sites? So in such patients, how do we filter out that group which is biologically known to do well? The other thing is the relevance of the circulating tumor cells. How do we find out that group of patients with circulating tumor cells which are yet to settle down, which are yet to metastasize? And once we detect the circulating tumor cells in them, what can we do to ensure that they do not progress? And finally, another very, very exciting thing that I've come across is that microRNA profiling. So miRNAs, they're known to regulate proliferation of tumor and apoptosis. So what they have found is these microRNAs, they're dysregulated in cancer and metastasis. So when they looked at oligometastatic and polymetastatic patients, they found that this particular microRNA 200C, was detected in elevated levels in those with polymetastatic breast cancer. So in the future, there is a possibility that we do microRNA profiling, and which may help us filter out the patients who are definitely going to do well. So is there any merit for breast surgery in the metastatic setting? Yes, but provided patients are appropriately selected for the same. It is very important to accurately stage the patient. We must be very careful and we must be very objective. We should not allow bias to cloud our judgment. We must have a very honest discussion in the MDT as to whether this patient is truly oligometastatic. So the treatment for each of the patients has to be individualized and has to be multidisciplinary in nature, so that we treat the patient, affording them a very good cure without impairing their quality of life. I would like to end my presentation by sharing a small snippet of information about this very, very inspirational lady. So the picture on my left is of Margaret Bulkley. This woman if I'm not mistaken, in the 18th century, or probably it was the early 19th century, at a time when we did not have women physicians or surgeons, she was so driven by her passion to become a surgeon that she dressed as a man for more than half of her life, and she served as a military surgeon. She changed her name to James Barry, and she died with the same name as well. Thank you so much. And once again, happy International Women's Day.
Thank you so much, ma'am, for the great insight on the oligometastatic breast cancer. That was really great information from your end. I would like to ask if anybody has any question. They can raise their hands and ask. Okay, now, so moving ahead, thank you so much, ma'am, for this presentation. Now, moving ahead, I would like to welcome Moving ahead, I would like to welcome our next keynote speaker, Professor Dr. Anita Ramesh. She is currently working as a professor and head of Department of Medical Oncology, Savita Medical College and Hospital, Chennai.
Yes, can you hear me?
Yes, ma'am. Welcome, ma'am, for today's webinar session.
Yes. Okay, we'll start right away. I'm unable to. Can you see my slides?
Yes, ma'am, we can.
Yeah, okay, fine. We'll just move it down like this because I'm unable to see that full screen for slide sharing. Okay, so a very warm welcome to everybody and a happy International Women's Day. Okay, as we go on to talk about the immunotherapy, and if you see the picture for William Coley and the birth of cancer immunotherapy, and you know even the last year's Nobel Prize was one of them awarded for this. So if you see, a lot of activities did take place in the past around vaccines and cytokines. People did discover T cells, which has detected as a tumor-associated activities. There were also attempts how to boost these T cell response by giving vaccines, and also attempt both the T cells as well as cytokines by using interferon therapy. Now, with the dawn of present, some drugs like the anti-CLA, which was seen to show some earlier studies which was done only on melanoma cells. And the sun continues to rise, and these anti-CLA antibody was seen to be present more on the melanoma cells. Now, what happens during these type of anti-tumor activity? So the drugs like ipilimumab, tremelimumab, nivolumab, and the anti-PLA L1 and PD1 antibodies, which like the pembrolizumab, atezolizumab, durvalumab, they cause the typical initiation of the cancer antigen presentation, priming, activation, trafficking of the T cells to the tumor, infiltration of T cells into the tumor, and recognition of the T cells, and ultimate death. And that's what an immune-mediated response looks like. Now, if you try to block this PD-L1 and PD-1 axis, or prevents the loss of T cell activity, and by blocking them, and that's what these monoclonal antibodies are doing, as shown in the figure, what we get is the tumor immune-mediated tumor cell kill. So the PD-L1 and the PD-1 exhibit similar early activities despite blocking, and so they help for the immune-mediated tumor cell kill. Now, this anti-PD-L1 and PD-1 in human cancers, it's seen in almost all cancers, around 13 cancers, including lung, head, neck, liver, breast, gliomas, pancreatic, gastric, ovarian, renal, and melanoma was the first one, colorectal, and even relapsed Hodgkin disease, there is a big role. So in the present focus of cancer immunotherapy is to enrich the responders to PD-L1 and PD-1 to identify most important which patients are going to be likely to respond to these anti-CTCLA and then anti-PD-1 and anti-PD-L1. So we need to find out those type of tumors. And as you know, the anti-CTLA is the ipilimumab, and the anti-PD-1, PD-L1 is nivolumab, pembrolizumab, atezolizumab. So this newer targets helps us to predict. So if you see that the tumor cells have a good expression of these tumor infiltrating lymphocytes, you get that brownish color, and that tells you how immune tumors are. And the PD-L1 expression can be enriched and is a surrogate marker for the responsiveness for the atezolizumab, both in non-small cell lung cancer as well as bladder cancer. So the predictive power of PD-L1 suggests the role that there is infiltrating immune cells in the function of this. So that's how the PD-L1 acts, and the infiltrating immune cell provides a co-stimulation and helps to activate. So, and when you come to the presently, these drugs which now used to increase the response rate. So what happens in immunotherapy? You may not be able to get a complete remission, but if you see the red color curve, it flattens out. Okay, so it gives you a prolonged, sustained survival. Okay, and the targets and chemotherapy, they should not interfere. And now is the era also with the combination of immunotherapy with other targeted drugs. So we did see many other targeted drugs, and the effects of using both together is now emerging. Yes, today we are going to restrict ourselves to the triple negative breast cancer as seen in the diagram. And once you see this curve, which says that the hypothetical curve and the optimal window for initiating the tumor combination cells, and ultimately it reaches an equilibrium. So, and the simultaneous combination may help to maintain the extended tumor flare state. That means if you see the arrow pointing here, okay, showing that if you give the immunotherapy and along with the chemotherapy, the responses are much more sustained. So it's an era of more of a combination therapy. And these doublets are there, PD-1 and PD-L1, as well as CTCLA. These are controlled together. And one of the example is nivolumab, but today we will restrict our discussion only to the use in breast cancer. So these endpoints in these trials shows that the overall response rate and the progression-free survival was underestimated, and the overall survival benefit in monotherapies with these inhibitors, okay, do give us a crossover from confounding and prolonging the study. But definitely there is an issue called pseudo progression, which is seen in the CT scan earlier, but that should not be, one should not be in a hurry to change the drug. And we focus on the newer generation of drugs, more targets to come. So the response to immunotherapy needs to be assessed, and we explore the entirely the cancer immunotherapy cycle. Now I will stop at this, and I will take you to my next slides on exclusively on triple negative breast cancer. If you see, 1 minute, just 1 minute. Yeah. So as we move on to the, so triple negative breast cancer is an area. Can you allow me to share my slides once again?
Sure, ma'am.
Yeah, just I'll just remove this. Yeah. Just allow me to share it once again. Yeah. Yeah. So now coming exclusively to maintain in the triple negative breast cancer setting, as you know, it's a heterogeneous group of tumors where they have several different subtypes, which has an immunomodulatory mesenchymal basal 1, basal 2 mesenchymal stem cell, and the immune mediated 18% of the triple negative breast cancers. And by the way, triple negative breast cancers does contribute 10 to 20% of all the breast cancer scenes. So in this 18% of the tumors do have the immune modulatory effect. So, and they are usually diagnosed at an early stage. Many of them undergo a very aggressive nature. They have a high mortality, they have a high incidence of spread, and they are usually larger tumors at diagnosis. And at this advanced stage with the triple negative, we do have paucity of drugs, and there is unmet needs. And they, as I told you, within the first 5 years, they spread rapidly, and the distant recurrence mean time is much lower, and there's a decrease in the 5-year overall survival rate. And most of the patients dies from this aggressive disease. So they have an overall a poorer prognosis, but then very important in triple negative, we should not classify all of them together, but we need to subclassify them depending upon the histology. Okay, and then if you see the stage wise, yes, the stage 1 disease does represent a little better survival, but stage 3 and 4 ultimately the chances of the survival are much inferior. Now, coming to the drugs which have been used for different types of these tumors, yes, atezolizumab, nivolumab, pembrolizumab has its role and been approved. And if you see the tumor tissue with the tumor infiltrating lymphocytes and the tumor bed, as we have learned all this earlier, the cancer antigen presentation, priming, activation, infiltration, recognition, and killing of the cells takes place. So this gives you a clue that more the tumor infiltrating lymphocyte, better will be the response type, and the subtype matters. So these are some of the studies where they have done with triple negative breast cancer patients, and every 10% increase in the tumor infiltrating lymphocyte, there is a reduction in the death rate. So it's a robust prognostic model, and which shows that there was an improvement in the 5-year survival with the amount of immunological implications are very, very important. So that also gives us a clue. The evaluation of the tumor infiltrating lymphocytes in breast cancer is one of the recommendation, and it also harnesses the immune response to cure of these disease. So we already heard about the immune checkpoint, how the PD-L1 and PD-L1 does, and how the anti-PD-L1 antibody blocks this pathway and restores the normal function. These are some of the papers showing in the triple negative. And one of the key articles was the Keynote 086, where they looked into pembrolizumab and a metastatic triple negative breast cancer and the SWOG study. And it seemed that the blockade combined with chemotherapy was rational. There was increase in the tumor infiltrating lymphocytes, more enhanced antigenicity, reduced local immunosuppression, and increased the PD-L1 expression. Even nab-paclitaxel with atezolizumab was again a chemotherapy drug along with the atezolizumab. It was a safety study, and it was seen that good response was obtained and not much side effect. 32 patients were enrolled, and the CR and the PR rate for all the patients in the first line. And one of the important studies is the eye impassion study, which did look into the use of atezolizumab, 840 milligram once in 2 weeks with nab-paclitaxel, and the other arm had placebo and the nab-paclitaxel. So they looked into overall survival, progression-free survival, duration of response, low response rate. Even the NYU looked into pembrolizumab and nab-paclitaxel, almost tied in the similar fashion with the placebo arm not having the immunotherapy. But still in triple negative breast cancer, there is a lot of high unmet clinical needs. OS is worse, recurrence is high, and the treatment limited options, and it's a more aggressive and heterogeneous group of disease. So this subset of triple negative is a potential target for immunotherapy. And these tumors are highly immunogenic with the PD-L1 expression, larger number of T-cell lymphocytes, and high mutation rates. And we have seen the data on the first line immunotherapy in this metastatic triple negative eye impassion 131, 130, and the Keynote with pembrolizumab. And many of the studies are now ongoing with immunotherapy and chemotherapy together, and the rate of expression. So this atezolizumab is a good anti-PDL antibody, and it is T-cell expression, and it prevents the destruction of PDL expression. And the rationale of combining this with nab-paclitaxel is synergistic. It does have a durable anti-tumor response, increases the number of tumor infiltrating cells, increased tumor PD-L1 expression, and the infiltrating CD8 T cells. So it does not hinder anywhere, but it induces more cell kill. So this primary endpoint of the IMPassion 131, which was a randomized trial looking into the first-line nab-paclitaxel with atezolizumab in locally advanced metastatic disease, and it came to a conclusion: the statistical significant progression survival benefit in the intent to treat population and the PD-L1 positive tumors. There was a meaningful overall survival benefit, and as well as the Keynote 355 did with adding of the pembrolizumab. So the chemotherapy for a triple negative breast cancer showed similar progression-free survival effect with IMPassion 31, okay, and evaluated to be used at atezolizumab, nab-paclitaxel in the first-line setting of the triple negative. And that's how we get into adding of immunotherapy in these tumors. The preferred neoadjuvant regimes for a triple negative, there is definitely anthracycline, taxanes, and cyclophosphamide will go without say for these tumors. And that's the PRO study assessment, which looking into the partial, we looked into the CR rate in these tumors, particularly T2, T4. That means we are now looking into a neoadjuvant scenario and to see how much is the tumor shrinkage, and the baseline remained to be the adjuvant period in both the arms, and was given to see whether how much of the response rate, that this pathological response rate with the combination was 57.6 versus 41, and the complete response rate was definitely higher in the combination. And if you see the median progression-free survival to the intent to population at 4 points, the curves did diverge. So giving a thought, yes, then the first line PD-L1 and the metastatic triple negative atezolizumab paclitaxel gives you an overall survival advantage and progression-free survival. Adding this did not improve the PFS or AS, reasons not determined. Pembrolizumab plus chemotherapy met the progression-free benefit. OS data is pending. Yes, taxanes appear to outperform gem-carbo, but yes, taxane remains the drug of choice along with nab-paclitaxel. So IMPassion is one of the key studies which gives you into the progression-free survival intent to treat population in these PD-L1 positive tumors, giving you an OS benefit. And atezolizumab and nab-paclitaxel was well tolerated, had a good safety profile, and was one of the first immune therapy adding the atezolizumab nab-paclitaxel for these patients of triple negative breast cancer. And this gives you a beginning of many of the other drugs to fall into the future. As of now, atezolizumab is approved. Yes, pembrolizumab is also approved, but then we also need to wait for further data. But you know, immunotherapy is emerging as an option for many of these tumors, and that brings us to the discussion by the use of other agents along with this immunotherapy so that we can get a better survival figures. And thank you. I'm happy to take any questions.
Thank you so much, ma'am, for the wonderful session. I would like to ask my participants that if anybody has a question, ma'am can address that.
Okay, I think there is no question also in the chat box. Okay, so yes, thank you very much. Thanks for having me here. Sorry, thank you. I'm on the way to the hospital. Thank you. Thanks,
thank you, ma'am. It was an honor to have you here with us. Thank you, ma'am.
Thank you.
So moving ahead with our next presentation, I would like to welcome our next keynote speaker, Dr. Sanjeev Kumar Agarwal. He is currently working as a senior consultant breast oncosurgery, Tata Medical Center, Kolkata, India. Welcome, sir.
Yeah. Good evening. Can you see my slide?
Good evening, sir. Yes, sir. We can see your slide.
So thank you for inviting me for this nice session, and happy International Women's Day to everyone who has joined to us. So my topic of interest today is auxiliary management after neoadjuvant chemotherapy. So it's specifically that the presentation is specifically target in the neoadjuvant setting. So please don't confuse it with the early breast cancer setting. I may go in an early breast cancer setting sometime to compare that what we are doing in the post-NSAT setting, or what we need to do in the post-NSAT setting compared to the early breast cancer setting for the axillary management in the breast cancer. So moving ahead, so what I want to answer the question, because axillary management in the post-NSAT setting is still debatable. So I can do something and I may say that I am right, and you can do something and you may say that you are right, because the data is very limited about axillary management in the post-NSAT setting, both in the escalation and de-escalation pathway. So what I want to answer is, sentinel lymph node biopsy as a technique is feasible and safe in the post-NSAT setting? First question. Second is, I will divide my presentation in two parts. One is node negative pre-chemotherapy and second is node positive pre-chemotherapy. So in the node negative group, can we do sentinel lymph node biopsy safely? What's the available literature and what we need to do? And can we avoid altogether sentinel lymph node biopsy? So no axillary staging, just like in early breast cancer, we are thinking as per the ongoing SOUND trial and INSEMNA trial. What about node positive? Shall we do sentinel lymph node biopsy? Shall we do axillary lymph node dissection, or shall we do axillary RT, or shall we do targeted axillary dissections? I would like to cover that. And if it is sentinel positive patient, shall we do ALND? Shall we do axillary RT, or we don't need to do anything as per the early breast cancer? Can the same thing can be applicable in the post-NSAT setting? Yes or no? So coming to the question one, can we do sentinel lymph node biopsy if you are seeing a patient in clinic? It's a CN0 to start with, clinically node negative. You advise the patient to go ahead with the NSAT for either achieving BCS, or if it is TNBC or HER2 positive disease. What is the data? What are the data for doing sentinel lymph node biopsy in this subgroup of the patient? So there are two major trials. One is Gnrh trial. So that's a prospective trial. It's a French multicentric trial. And they have included node negative patient, given chemotherapy, remain node negative, and they have done sentinel lymph node biopsy in this group of the patient. And the identification rate was 95%, and the false negative rate was 8%. So if you will see the study, it has the outcome in the acceptable range. So as per the sentinel lymph node biopsy, we say that if the identification rate is more than 90%, and if false negative rate is less than 10%, it's acceptable outcome. Similarly, if you will see the retrospective data of MD Anderson, so clinically node negative to start with, and 575 patient, identification rate was 97%, and the false negative rate was 6%. So as a technique, what we found in the node negative patient, pre-chemotherapy, after NSAT, if you're doing sentinel lymph node biopsy, it has acceptable identification rate and false negative rate. Coming to, do we have any outcome data about this? So this is the again French multicentric study, Gnrh study, and you can see that they have included both CN0 and PN1 patient in this study, out of which 589 patients were CN0, and they have done sentinel lymph node biopsy, and if sentinel was negative, no axillary lymph node dissection was done. And the outcome data is there was only one axillary recurrence after 36 months of median follow-up. So this was a prospective multicentric study, node negative patient, post chemotherapy sentinel was done, and if the sentinel was negative, ALND was omitted or avoided, and we have seen that the outcome data was fairly acceptable data. So with these 2 or 3 studies targeted to CN0 group, what we found that in the node negative patient, the post-NSAT sentinel has acceptable identification rate and false negative rate, and the outcome data was safe also. So moving ahead, so what we have done, so after these data were around 2017 to 18, it was all published, and we have changed our practice in node negative pre-chemo. If you are giving NSAT, we are doing sentinel lymph node biopsy, but what's the positivity rate? In how many patients we are actually seeing the sentinel lymph node being positive? So this was a nice study published in Cancer 2020, and you can see that the list of trial where it was node negative initially, and the sentinel lymph node biopsy was done post chemotherapy, And if the patient is achieving PCR, you can see in the first study around 5,377 patients. And in the HER2 positive and TNBC group, if the patient is achieving PCR, the nodal positivity is only 1.6%. So if you are doing 100 sentinel lymph node biopsy, and if they are achieving PCR, the chances of finding sentinel positive is only 1.6%. And mind you, the false negative rate is around 5 to 7% in this group. So people are asking question, why we are doing even sentinel lymph node biopsy in this group? Similarly, in the lower down 3 study, one of 98 and 986 patient and 2 are of smaller study. In the smaller study, it was around 0%. So we have started doing sentinel lymph node biopsy in this subgroup of the patient, and our data is almost matching. So we have done around 112 patient in the last year. It's 1 year data. And the nodal positivity rate was only 3% in this group of the patient. And if there was breast PCR, the nodal positivity was 0%. So we are also thinking that can we avoid doing altogether no axillary staging in this subgroup of the patient? With this thing in the mind, the German group has started a trial. So you all should read or you should be aware of this trial. It's a German breast group trial, and popularly known as U-Breast-01 trial. So what this trial is doing, so this trial is recruiting patient CN0 to start with, T1C to T13 CN0 patient, TNBC in HER2 positive patient, giving chemotherapy. After chemotherapy, you are doing breast conservation surgery first. So only wide local excision first. See if the PCR is achieved or not. If there is a PCR, no axillary sentinel lymph node biopsy. So the target recruitment is around 267. And probably in this group of the patient, especially in the TNBC and HER2 positive, node negative to start with. And if you are doing breast surgery first, and if you are seeing that it's a PCR, probably you can avoid the axillary staging altogether after publication of these results. And retrospective data is also showing in the same direction. So the node negative patient, what I want to summarize it, if a node negative patient, pre-chemotherapy, you are giving NSCT for a specific purpose, you can do sentinel lymph node biopsy as per the current data. And maybe we were moving forward to no axillary sentinel lymph node biopsy if you are achieving breast PCR in TNBC and HER2 positive patient with this prospective trial recruitment. So this is all about node negative patient pre-chemotherapy. Coming to the next group of the patient. So if you are seeing a patient node positive and you are giving chemotherapy, can we do sentinel lymph node biopsy in this group of the patient if they were converted to N0 post chemotherapy? So what's the literature available and how we should proceed? So these are the 3 trials which had asked this question in 2015, around 2015. And they wanted to know the answer, feasibility and accuracy of sentinel lymph node biopsy after NSCT in a node positive patient who converted to node negative post chemotherapy. In all these trials, the goal to achieve false negative rate less than 10%. Let us see the result. So what the study, you will see that in the first study 603 patient, second study 592 patient, and the third study SNFNSC study 153 patient. So if you will see the false negative rate in the whole group was more than 10% in every study, and the goal was to achieve false negative rate of less than 10%. Coming to when it was less than 10%, so if we are using IHC in the frozen, the false negative rate was less than 10%. If we are using dual dye in the 2 study, in Sentinel and SNFNSC study, false negative rate was less than 10%. If you are removing 3 or more lymph node, then the false negative rate was less than 10%. And if you are removing clip node, what is clip node? You are putting a marker in the positive node before chemotherapy, and you are removing this node also. In the ACOS American study, it was around 6.8%. So let me summarize the whole thing. So What was the summary of all these major trials? So overall, FNR was greater than 10%. The FNR was less than 10% in selected group of the patients. So these were all subgroup analysis. So if you are using IHC infusion, but IHC infusion, we all know as a pathologist or as a surgeon, it's costly and time consuming. And IHC in the frozen section is not available in every center. Second, if you are removing 3 or more sentinel lymph node, so if you will see the median number of sentinel lymph node removed in all the early breast cancer or even the post-nicity study is less than 3. So almost you will not achieve this target in more than 50% of the patient or around 50% of the patient. You can use dual dye. Dual dye is easily available across the world, and probably now it's slowly getting available with the help of ICG dye in the developing country also. Or you can think for the clip node removal, and the lowest the FNR was with clip node removal of 6.8%. So what is clip node removal? It's popularly known as targeted axillary dissection. So what is targeted axillary dissection? So node positive patient, you are giving chemotherapy. Before chemotherapy, you are clipping the most suspicious node, and after chemotherapy, you are doing sentinel lymph node biopsy plus removal of that clip node. So that's popularly known as targeted axillary dissection. Let's see what's the result of the targeted axillary dissection. So the first study was from MD Anderson itself. So they have used radioiodine seed to localize the clip node, and you can see that the false negative rate was 4.2%. So it was less than 5% with the sentinel lymph node biopsy plus clip. It was less than 5% with the clip node removal only. And clip node was not amongst the sentinel node in around 25% of the cases. So if you will do sentinel lymph node alone, probably you will miss the metastatic node in 1 out of 4 patients. It's around 23%. So let's see the data all together. What was the false negative rate? So with the sentinel lymph node biopsy alone in this study, false negative rate was 10.1%. With the clip node removal, the false negative rate was 4.2%. And when you are combining the two together, the sentinel plus clip node, the false negative rate was 1.4%. So what we have understood from the targeted axillary dissection, it generally gives you a way ahead acceptable false negative rate. So the whole idea was revisited by the Netherlands group. What they have done, they have put the marker before chemotherapy. You can see here the marker, and they placed radioactive seed to mark this clip, and they used radioactive seed to remove this marked node. They have not done sentinel lymph node. After chemotherapy, they have removed only the node with the metastatic history. So that's the clip node removal only, and the false negative rate was around 7%. So even if you are removing clip node only, not doing sentinel, probably clip node only is also the false negative rate is less than 10%. That's the message I want to give. So you all know the radioactive seed is not available everywhere in the developing country, and there is a problem of disposing radioactive seed if you are working in a small center. So is there another way of localizing the clip node? So yes, there are multiple ways, and it was published also. So you can use ultrasound guided wire localization of the axillary lymph node. So there was a single center study from the Germany, and they tried to localize the clip by placing wire and do USG wire localization. But if you will see that the failure rate here was around 30%. So what we understood that probably wire localization of axillary node is not working in many centers. Coming to, is there another technology? So you can use localizer. So Sabre, Scout, Maxit, and these all are very easy technique, but it's very costly. So there was one study from the TMH Mumbai also, where they have compared sentinel lymph node biopsy with low axillary sampling. So in the TMH Mumbai and many center, people do low axillary sampling. They included all patient N1, N2, and they have done sentinel lymph node biopsy majority with the dual dye, and they have compared the result of sentinel lymph node biopsy with the low axillary sampling in this particular setting. And what they found that the false negative rate with the low axillary sampling was less than 10%. With the Sentinel in the TMH study was around 20%, but the median number of lymph node removed in the low axillary sampling was 7 in this study. So the median number of lymph node was more than 4. And we all know that if you remove more than 4 lymph nodes, the chances of lymphedema slowly increase. So combining all together, how to reduce FNR less than 10% in post-necessity setting in the node positive patient. So you can see that you can use dual dye. Yes, in the developing country, we can use ICG. IHC on frozen is challenging, costly, and time consuming. Greater than 2 sentinel lymph node, yes, you can try, but it's not possible in all patients. Axillary sampling plus sentinel lymph node biopsy, yes, is the false negative rate is 9.1%, but it has associated with high number of sentinel lymph node removal. So median number of sentinel lymph node removed was around 7. What about targeted axillary dissection here? FNR is less than 5%. Radioactive seed was the mostly used in this setting, but it's not available everywhere, and there is a legislative issue for the disposal. With the wire, false negative rate reported was 0%, but it's a difficult procedure and it's a high failure rate for localizing clip node in the axilla. GPS clip technology, yes, we can use. It's easy, but it's costly and it's not available everywhere. So to reduce FNR of less than 10%, you can think what we understood that we need to do more than sentinel lymph node biopsy. So either targeted axillary dissection or low axillary sampling. Let's move and see, do we have any outcome data? So what I mean by the outcome data is node positive patient converted to node negative post chemotherapy. And we have done sentinel lymph node biopsy, and we have not done axillary lymph node dissection if sentinel was negative. Yes, there are 2 major outcome data. One is axillary recurrence after sentinel lymph node biopsy, patient treated with neoadjuvant chemotherapy. This was a retrospective data, and they concluded that axillary recurrence was only 0.7%. So it was retrospective data. Coming to the prospective data from MSKCC, it was published recently in the last year. So what MSKCC experienced about doing sentinel lymph node biopsy in the node positive patient post chemotherapy. So they included 610 patients in this study. Tumor size T1 to T3, N1 disease, biopsy proven. 555 were converted to CN0 post chemotherapy. 234 patients, means 42% of the patient, were having more than 3 sentinel lymph node removed, and all sentinel lymph node were negative. So axillary lymph node dissection was not done in 42% of the patient out of 610 patients. What's the outcome? 1 axillary recurrence in 40 months of median follow-up. But when I dissected the data of MSKCC, if you look this paper carefully, what you will see that 70% of the patient received axillary RT. So the true de-escalation of no axillary treatment was there in 11% of the patient only. So what they have done, if they were not doing axillary lymph node dissection, they have covered the field with the axillary radiotherapy. And the majority of the patient in this group were HER2 positive and TNBC, so chemosensitive tumor. So probably if you are thinking to do sentinel lymph node biopsy only, not doing targeted axillary dissection or low axillary sampling, probably you need to be super selective in selecting the patient for sentinel lymph node biopsy only, and you need to remove more than 3 sentinel lymph node. So node positive pre-chemotherapy, we can reduce FNR by using dual dye, IHC in frozen, greater than 3 sentinel lymph node removal. Most effective method is targeted axillary dissection with FNR of less than 5%, but it's technically challenging and the facility is not available everywhere. Low axillary sampling is possible alternative here, but we need to be careful because it's an advanced disease, and level 1 evidence with robust outcome data is required to change the practice in this particular subgroup of the patient where FNR is more than 10% with sentinel lymph node biopsy only. Coming to the third question, do we need to do axillary lymph node biopsy in low burden sentinel lymph node positive patient in post chemotherapy setting? We all know with the data from early breast cancer by G11 data and IBCSG data that if the sentinel lymph node has limited metastasis, means up to 1 or 2 node positive in T1, T2 patient, we can avoid doing axillary lymph node dissection. Is it hold true same for the post-ethnicity setting? So this study was the major study. It was published in 2018. There is low volume disease in the sentinel lymph node after neoadjuvant chemotherapy as an indicator for axillary dissection. So what was the result here? So they included 722 patients. It was a single center study, and what they found that with the ITC in the sentinel lymph node biopsy in the post chemotherapy setting, they have done axillary lymph node dissection in every patient, and they found that 17% of the patient had additional nodal metastasis. With the micromets, it was around 60%, and in the macromets, it was around 63%. So if you will see the non-sentinel lymph node positivity in G11 and IBCSG ALND arm was around 15% for IBCSG and 27% for G11. But when you will compare this to the post-chemotherapy setting with this study, non-sentinel positivity was 17% for ITC and around 63% for the macromets. So what we understood by seeing this study that LND should be done or axillary treatment should be done in all sentinel lymph node positive patients if you are doing it in a post-chemotherapy setting, not in upfront setting. So this study make it clear that we need to do axillary clearance or axillary treatment in all sentinel lymph node biopsy positive patient. So next question, if sentinel lymph node is positive or metastatic, can we replace axillary lymph node dissection with axillary RT? So in early breast cancer, we all know there is an AMROS trial. So it was a randomized controlled trial, non-inferiority trial, where they compare axillary RT with ALND in SLN positive patient, and it has equivalent outcome result. Can we apply same thing in the post-ethnicity setting? So there is a prospective trial, Alliance trial. So what Alliance trial is all about, you all should be aware of. It's a clinically T1 to T3 N1 M0 breast cancer, neoadjuvant chemotherapy. After that, you are doing sentinel lymph node biopsy if the N1 has been converted or rendered to N0 post chemotherapy. And if sentinel lymph node is coming as positive, the patients were randomized in two groups. One group is having ALND and another group is not having any axillary surgery and receiving breast, chest wall and nodal RT. So altogether is 1660 patients. Primary outcome is invasive disease-free survival, and secondary outcome is OS and invasive local regional recurrence-free survival. This result will come in 2025. Probably the target is to target result publication in 2025 as per the clinical.trial.gov as the information given by the PI. And probably this will change the practice towards axillary RT if sentinel lymph node will come as positive in post-ethnicity setting. Maybe we have multiple options of having either doing axillary lymph node dissection or axillary RT in post-chemo setting. To conclude, what I want to say is in node negative patient, if you're giving chemotherapy, you can do sentinel lymph node biopsy post-chemotherapy. And if sentinel is coming as negative, you can avoid axillary clearance. There is a way forward of thinking of no axillary staging if the patient is achieving breast PCR. There is an ongoing trial, UBreast01 by German group, and probably this will answer this question. In the node positive patient, if you are doing sentinel lymph node biopsy alone, be careful in selecting patient. Try to use dual dye. If you have facility or if you have training of targeted axillary dissection, that's the preferred procedure. And if you are doing low axillary sampling, as per the TMH study, false negative rate is an acceptable limit. In what's the level 1 evidence for the outcome data? Still, there is no mature data for using sentinel lymph node biopsy in this group, I must say. Can we do, if the sentinel lymph node is positive, at present, we should do axillary lymph node dissection because non-sentinel metastasis rate in post-chemo setting in node positive patient is very high. And if Sentinel is positive, can we replace the ALND with auxiliary RT? We need to wait for the result for Alliance trial. So with that, I want to conclude the auxiliary management in the post-necessity setting, and I'm happy to answer any question if you have.
Thank you so much, sir, for the wonderful presentation. I would request the audience, if they have any questions, they can ask sir now.
Okay, I think if there will be any question, I can answer in the chat box also. So you can move forward.
Okay, thank you so much for your presentation, sir. Now moving ahead, I would like to welcome our next keynote speaker, Dr. Jayanti Thumsi. She is currently working as lead surgeon, Department of Breast Oncology, Apollo Hospital, Bangalore, India. We welcome you, ma'am.
Yeah, thank you very much, everybody, and a very, very happy Women's Day, and thank you for having me here. My presentation is very, very basic, and because I was told there were a lot of students in the audience, so my presentation is going to be very basic. All right. So the topic that I will be speaking on today is breast cancer in young. Is it any different? Is there any difference than what we see in the older age group, right? So breast cancer, we all know, is the most common female cancer with estimated age standardized incidence of 71 in 1 lakh women. In spite of this high number, breast cancer has one of the highest 5-year survival rate of 81.89%. Breast cancer in young is a very complex disease, and certainly multidisciplinary approach is mandatory. Now, who are these young patients? Young patients are those who are less than 40 years of age at the diagnosis of breast cancer. In India, the statistics suggest that 4% of breast cancer that happens in India are in the age group of 20 to 30%. 6% of them are in 30 to 40 years of age group, and 28% of the women are between the age group of 40 and 50 years. So there are certain unique issues in young adults with breast cancer, those who are less than 40 years, and what is the difference? First of all, there is a delay in the diagnosis because the warning signs which are seen are often ignored by the patient themselves and also by the doctors. One might feel that they're too young to get breast cancer. Also, diagnosis itself is very difficult because breast tends to be very dense when the patient is younger, and we have very limited radiological or imaging options to detect the disease at an early stage. In younger adults, the disease tends to be very aggressive. By the time a lump is felt, the cancer may already be in an advanced stage. Unique issues in young adults with breast cancer diagnosis causes a lot of psychological issues along with the medical issues. It's very shocking, and it often happens at a time in life, most often when it is focused on family and careers. The young adults with breast cancer tend to have unfavorable biology. These are fast-growing diseases with higher grade. Triple negative and HER2 positive are more common, 23% as against 17.2% and 41.8% as against 23%. As compared to older women who mainly have luminal type of breast cancer, these younger women tend to have more of triple negative and HER2 positive disease. Breast cancer in young is biologically a distinct entity beyond subtype distribution. They also tend to have poorer response to the treatment. In addition to this, there are unique psychosocial problems of premature menopause, fertility, and issues of sexuality. How to diagnose as any breast disorder? clinical diagnosis, triple assessment, imaging, and tissue diagnosis. In breast imaging, we have very limited options in young patients. Mammogram is not very informative as the breast tends to be very dense. Ultrasound breast is an alternative but may not be sufficient. Breast MRI has its own limitations because it is high on sensitivity but low on specificity, but it can certainly be used in equivocal mammogram or in ultrasound. Tissue diagnosis, FNAC versus true-cut biopsy. True-cut biopsy is the preferred because IHC can be done in these cases. All cancers have a genetic basis, but not all cancers are hereditary. In young patients with breast cancer, always BRCA testing has to be advised. Genetic counseling and testing are an integral part of breast cancer treatment in young adults. Approximately 10% of breast cancer in young patients are associated with mutation in BRCA1 or BRCA2, and 1% of them with other mutations. So knowing the genetic part of the breast cancer is very important because this can change both the primary surgical management, whether we do MRM or breast conservation surgery, the decision also depends on whether the BRCA1 or 2 is positive or not, and also subsequent follow-up like radiological surveillance or risk reduction surgeries. It also has therapeutic implications. PARP inhibitors like olaparib, etc., are useful in patients with BRCA mutation. The treatment options are locoregional therapy and systemic therapy. Surgery, radiation therapy, are locoregional therapy, and systemic therapy, chemotherapy, hormone therapy, etc. Locoregional therapy, issues of femininity need to be addressed. Cancer clearance with good cosmetic outcomes should be the focus. Breast conservation surgery is preferred, and margins should in particular be checked as at young age. Young age is an independent risk factor for local recurrence. Overall survival is the same in patients going through MRM or breast conservation surgery. If a mastectomy is needed, skin sparing or nipple areola sparing mastectomy with primary reconstruction should be done if it is oncologically feasible. So these are breast conservation surgery photos of 37 and 34 years old. This is a scarless oncoplastic breast conservation surgery. This is bat wing oncoplastic surgery again. You can see the scar. This is for the larger tumors, breast conservation surgery with LV flap reconstruction in younger patients. This again with larger tumors, quadrantectomy with LV flap reconstruction. This patient had bilateral lumpectomy with LV flap reconstruction. You can see LV flap reconstruction after mastectomy with implant in place. This patient, we have done skin and nipple sparing mastectomy with implant reconstruction. This again is implant with LV flap reconstruction. Now, radiotherapy, given the higher risk of local recurrence after breast conservation surgery, a boost to the site of excision should be routinely done. Partial breast irradiation is contraindicated in these young adults. The indications for post-MRM irradiation should not discourage one from doing primary reconstruction of the breast, given the high-end radiation machines that are now available. There are a lot of effects of local therapy, which includes surgery and radiation therapy. It alters body contour and issues of body image are seen. Chronic pain syndrome, it may affect sexual life. And generally, mastectomy has more negative impact than breast conservation surgery. Recommendations for chemotherapy are based on age, tumor subtype, grade, vascular invasion, proliferation rate, hormone receptor and HER2 receptor expression, and the stage of the disease. In view of long life expectancy, side effects of adjuvant therapy need to be carefully balanced against benefits, and long-term morbidity should be monitored, like cardiovascular, bone health, cognitive impairment, and premature menopause. Impact on fertility and available preservation measures should always be discussed in women who are young and develop breast cancer. Modern anthracycline taxane-based chemotherapy regime for 8 cycles are unlikely to cause permanent amenorrhea in women who are less than 40 years and almost nil in women who are less than 35 years of age. Tamoxifen is effective in patients with hormone receptor positive premenopausal women. But young hormone receptor positive ones show high risk of long-term relapse and worse 10-year breast cancer specific survival independent of nodal status as compared to the older patients. Extended hormone therapy for 10 years instead of 5 years with tamoxifen has shown to be beneficial, reducing the disease recurrence and mortality. Benefit of ovarian functional suppression, either with temporary LHRH agonist or permanent bilateral salpingo-oophorectomy, has been debated. High-risk patients should receive ovarian function suppression in addition to oral hormone therapy, and lower risk patients should not receive the ovarian function suppression. Effects of systemic therapy. Breast cancer may occur at a stage where family has not been completed. Chemotherapy induces amenorrhea, which could be temporary or permanent. Chemotherapy drugs are directly toxic to the ovaries. It also may cause diminished libido and decreased fertility. Fertility preservation options should always be discussed with every woman, regardless of age, who are young and develop breast cancer. Cyclophosphamide, carboplatin, and adriamycin reduces the ovarian reserves. In general, all women with breast cancer who are in their reproductive years should be counseled regarding fertility preservation, ask about their pregnancy desires, and refer to the fertility specialist at the earliest. There are many fertility preservation options. Due to the improvements of cancer treatment, the survival rate has increased. Loss of fertility is a major issue. Having a family is an important aspect for long-term survivors. Ovarian preservation with Gnrh agonists is the only option that does not involve assisted reproductive techniques. Gnrh agonists stop ovarian follicular development by suppressing gonadotropins, which can protect a woman's ovaries from damage due to chemotherapy. Of course, the efficacy has not yet been established. Embryo and oocyte preservation is the other alternative. The most effective approach is embryo cryopreservation. It requires in vitro fertilization and a participating male partner or a sperm donor. Oocyte and ovarian tissue cryopreservation, no male partner is required in this technique. Currently, it is investigational and lower pregnancy rates are seen as compared to embryo cryopreservation. Ovarian tissue cryopreservation is preferred when neoadjuvant chemotherapy is planned because it does not need ovarian stimulation, is independent of the phase of the menstrual cycle, and can be rapidly performed. However, the presence of malignant cells in the ovary need to be excluded, especially in BRCA carriers. It requires controlled ovarian stimulation associated with a marked increase in estradiol levels. Hence, exogenous FSH and aromatase inhibitors may be the optimal strategy in such patients. Contraception and pregnancy after breast cancer treatment should certainly be discussed with these patients. All premenopausal women diagnosed with breast cancer should be counseled regarding future fertility and contraceptive options. Oral contraceptive pills in these patients should be avoided. Intrauterine devices or barrier methods are much safer. There is no clear increased risk of recurrence from having a biological child after breast cancer treatment. Cancer survivors have a lower pregnancy rate than controls. Breast cancer survivors in particular have 70% lower chance of pregnancy as compared to the healthy count controls. The future pregnancy after breast cancer treatment, as most recurrences of breast cancer happen within 2 years of diagnosis, it is recommended to wait for at least 2 years from remission prior to conceiving. Chemotherapy agents can also cause infertility. If a patient desires future fertility, referral to a fertility specialist to discuss egg, embryo, or ovary freezing should be prudent. Breastfeeding should be encouraged. In general, loco-regional treatment of breast may affect lactation, and many patients can breastfeed only from the contralateral untreated side. Hormone therapy and pregnancy. ER/PR positive breast cancer are treated with tamoxifen, now given for 10 years. With continued use, in 50% of these women, their menstrual cycle becomes less regular or sometimes stop. Patients are advised certainly not to plan pregnancy while on tamoxifen. Can women choose to take a break from hormone therapy if they want to try to get pregnant? It is still on trial, a trial called Positive Trial, that is Pregnancy Outcome and Safety of Interrupting Therapy for Women with Endocrine Responsive Breast Cancer, is looking into the safety of interrupting hormone therapy to try to get pregnant. Psychological issues are something which also need to be considered while treating them for breast cancer. Young women with breast cancer are likely to have more psychological issues as compared to their older counterparts. Increasing number of patients have long-term survival, but the quality of life may be jeopardized because of the effects of multimodality treatment. Risk of premature menopause, cognitive impairment, late cardiac toxicity, second cancer, persistent fatigue, neuropathy, sleep and mood disturbances, and psychosocial consequences need to be addressed. Mindfulness meditation has proven to be promising. Maintaining a healthy lifestyle, regular exercise, healthy eating habits have shown to be beneficial. The return to work in the cancer survivors need to be emphasized. In summary, I would like to say that breast cancer in young is on rise. Management of young breast cancer patients is complex. It occurs at a time in life most often reserved for family and career. Young women tend to have more aggressive disease, often diagnosed at later stages than their older counterparts. Mastectomy does not offer better overall survival than breast conservation surgery, which can safely be done. Genetic testing should be considered early after the diagnosis, as it may influence the treatment decisions. The outcomes of treatment for breast cancer in young are good if detected early and treated appropriately with correct modality of treatment. Young breast cancer patients face different problems compared to the older women, including fertility, pregnancy, late treatment side effects, social difficulties as job discrimination and childcare. Fertility preservation options should be discussed in appropriate cohort of patients. It's not only a scientific issue, but also a psychological and a social issue, and multidisciplinary approach to treat them is certainly encouraged. Thank you very much, dear friends, and for this opportunity. Thanks a lot.
Thank you so much, ma'am, for such an enlightening presentation. I hope we learned something from your presentation, definitely. I would now like to request the audience, if they have any questions, we can proceed with that. Ma'am, I had a question if you allow me to ask.
Yes, please.
Actually, I came across an article in the American Journal of Preventive Medicine. Like the title of the article was Breastfeeding and Breast Cancer Reduction, Risk Reduction. So, ma'am, can I know your views on that?
Your breastfeeding is known to reduce the risk of breast cancer, as we all know for sure. But post-treatment, the loco-regional treatment for breast cancer does affect breastfeeding in the future, especially when we do breast conservation surgery and we do radiation therapy. The milk production in that particular breast seem to be affected, but breastfeeding from the other side can safely be done.
Okay, ma'am. Okay. Okay. Thank you so much, ma'am. Any other question from the audience?
I can answer in the chat box as well.
Sure, ma'am. Thank you so much, ma'am, for your presentation. So moving ahead, I would now like to welcome our next keynote speaker, Dr. Gayatri Iyer. She's currently working as consultant radiologist in Chennai Breast Institute, Chennai, Tamil Nadu, India. We welcome you, ma'am.
Thank you. Thank you so much for having me here. Happy Women's Day to everybody. Am I visible?
Yes, ma'am, you are visible.
Okay, so I'll just start sharing. Are you able to see my screen?
Yes, ma'am, we can see your screen.
Yes. So thanks for having me here. So I'm going to talk today about the value of radiology, and which is of paramount importance in early detection of breast cancer, where it's screening as such in India. Screening is not performed, but how we can filter out from screening is not a diagnosis. It's just a perception of an abnormality. But through this, we finally come to and detect many unrecognized conditions, and in populations which even we might not expect. Even younger population, as previous speakers mentioned. So here we can see we screen out the from the gross abnormalities, we finally come to the real abnormalities which we have to deal with. So this is again a representation where the gross abnormalities can be excluded by self breast examination. Then if we detect something there, clinical breast examination is done. And then also we find something suspicious, we go to radiology comes into play, where we do mammography. And based on the mammographic findings, we then diversify into various other modalities. So this is what I just mentioned. So breast self-examination, which is mandatory for everybody. Then if they suspect something, anybody, the 4-finger test, which we advise, the clinicians, they advise, which everybody should do. If the patient, if the people, women, they find something, then they come for clinical breast examination, and then a mammogram is done, and then comes ultrasound. If we see something suspicious, then only ultrasound is done. Generally, ultrasound is targeted, and then also as equivocal findings are there, or in high-risk patients, we do go to breast MRI then. But in all these, the gold standard is a mammogram, which is basic, but it's gold standard, very informative. Even if it is, and with the present technology and the latest advances, even if in a dense breast, we can really find out hidden abnormalities. So breast ultrasound, as I said, it's not a screening modality. Whenever we see something suspicious or abnormal in a mammogram, then only we refer the patient for a ultrasound. Otherwise, not for every patient, we do a breast ultrasound. A very fatty breast, we don't need an ultrasound. Or a breast where we don't see abnormality, it's all glandular, fibroglandular tissue. We don't think an ultrasound is needed. We will not call the patient for ultrasound. And ultrasound has its own positive and negative. It's highly observer dependent. It's dependent on the skill of the person who's doing it. Then it's time consuming also. We do generally for every person, we do both sides, mammogram or ultrasound or any radiological modality which is brought into use, both sides are done. And automated whole breast ultrasound may play a role in future. We have yet to wait and see how it plays out. Breast MRI, it's indicated in high risk screening, where a young patient or BRCA positive patients, it's not for a overall population based screening, because we all know MRI has a very high specificity, but it has a very low sensitivity. So it can pick up something, a lot of information it picks up, but we don't know. We generally have to filter out what is relevant, what's not relevant. So MRI in general is not used in high risk in screening. It's only used in high risk screening. Now, population-based screening is widely practiced in developed countries, where we send an invite to the targeted population. We ourselves will send them an invite, and it's a proper, well-audited system in place where we supervise and monitor all the steps of the screening process. There are very comprehensive guidelines and protocol. And not only that, at the back end, there is a quality assurance structure for checking whether the technique as well as the technology, everything in this place, and the final product should meet certain standards. Now, the steps in the screening processes, again, as we said, invitation to the eligible population is given, which is mostly above 40 years in India. Screening process can be done in a standalone mobile units also. It doesn't need a radiologist in place or a specified breast clinic. It can be done in a mass place where, we have just machines, and we do in a mass level, we do a large volume based breast screening. Then we do a centralized reading. Reading is very important. And one of the most important things in reading, I would say, is always we should compare it with the previous mammogram. That is very, very informative. So we have a very then targeted approach, and we are sensitized more when we read mammograms when we have the previous mammogram. So it's very important for that. Very many places, unfortunately, we don't have it, and due to a lack of technique or technology, and it's missed. And thanks to the filmless processes, now we have packs in place where we can do it. Even if the patient loses the films, the radiologist or the clinics, we have it. Then there should be a standardized reporting. Assessment clinics for screen detected abnormalities, there should be a proper protocol. Whenever we detect an abnormality finally during the screening process, there should be a protocol which should be followed to finally bring it to a final conclusion. Then a quality assurance structure, as I said. Now, screening pathways, if we do a screening which is 2-view mammography, we all know craniocaudal and mediolateral oblique view, we take 2 views. If it is normal, then we rescreen in 2 years. If it is abnormal, that is BI-RADS 045. 0 is where it's incomplete, 4 is where there is suspicion, 5 is where there is definite malignancy. Then we recall the patient and reassess. If there is cancer, we'll go ahead with the protocol-based treatment. But if there is no cancer, the patient goes back into the rescreening once in every 2 years. So the screening pathway, the machine is very important as radiology. A lot of us, we depend mainly on the quality of the machine, the latest advances, the technology, and we fine tune it, we bring it to use, but the technology helps us to, give our services. So quality assurance, quality control, then technologists help us in a big way. The proper training of the technologists and the staff and has to be done for the proper positioning of the patients, to assess the film, because it involves radiation. We can't keep on taking reviews. So the training of the technologists is very, very essential. Reading, of course, radiologists, it's a very, very radiology. In radiology, breast imaging is very cliche. It's very streamlined. So anybody who's well trained will be easy. It will be easier for them, and it will be fine. They will be fine tuned to pick up abnormalities than a general radiologist. So audit of diagnosis rate should be there, where we should keep rechecking what are the missed and the interval cancers and recalls. Even a small, many cases we see where within 1 year there will be a small change, a subtle change, but we can pick it up. Those are the ones we are targeting more in screening processes, these interval cancers. And of course, image archival, as I said, PACS is very important, picture archiving system, communication and systems, where we need the IT to help us with that. And because, as I said, previous comparison with previous imaging is very basic and very essential, but it's also basic, very essential. And diagnostic facilities. So breast imaging is more of a one-stop solution place where we diagnose and we do tissue diagnosis, and then finally we not only interpretation, we do tissue diagnosis, and finally give the surgeon what to do, and then they get the whole idea, they not only by imaging, they get a 3D view of to plan their surgeries, but they get a tissue diagnosis also of how to further process it. So screening pathway assessment, the assessment is of screen detected abnormalities. As I said, there can be need for additional mammographic views apart from the regular craniocaudal and the mediolateral oblique views. If we see very subtle calcifications, microcalcifications on the gross view, if they are not suspicious, we would like to take then magnified views, and those magnified views, that also tomosynthesis now we are using, which gives us the 3D view in sections. We can see every breast section we can see, and then we finally come to a conclusion. In ultrasound, we see the gross abnormality where there's a mass lesion, which is a solid or cystic mass lesion we can see. And then we go to biopsy based on the requirement. So this should be done. So as I said, mammography can be done at the standalone clinics or mobile units. But as we progress, breast ultrasound, biopsy, all this should be done at specialist units where the radiation, the requirement of the patient, and it's a one-stop solution. It should be where the entire unit or team is well trained to address the entire issue. And the outcomes in breast imaging, as again I'm saying, the outcome should be followed up, because mostly we do this yearly basis or once in 2 year basis. So they are followed up, compared, and then we come to a conclusion every time. So for example, in this a particular image, we can see that this is a breast craniocaudal and a mediolateral image, where we can see the between the breast tissue, there is a dense area, but it is somewhere getting hid in the breast tissue. So now for this here, we have taken a magnified view where then we can finally see a very, very irregular, speculated, mass, small mass, which is not even palpable and which is causing locoregional architectural distortion. So this is how we have to streamline or fine-tune our images, where something is seen, but it is hidden, not very well seen. So we, based on that, we need to take further views. Then when we saw it on the magnified view, we did an ultrasound, where we can see there is a solid microlobulated mass, very small, although non-palpable. And then we put color, we see increased vascularity in the lesion. In elastography, again, this is a additional, and it is a helpful technique where we see on a shear wave, we can see the hardness or the stiffness of the lesion. The harder or the stiffer it becomes, the more malignant it is. So here we can see there is mixed color uptake. So we can say that it's harder in the center, more towards the center, the lesion is harder, and which correlates to the other imaging also. Again, so here we have done now a targeted excision of this lesion has been done with wire localization. So it's a very targeted approach where imaging helps the surgeon we guide them to do a targeted approach. So this is an example where on a mammogram, we can see only microcalcifications. Microcalcification, that too on magnified images. In this lesion, obviously it was not palpable. After mammogram, we saw that it was not visible on an ultrasound. So how to do a biopsy? So this is a non-palpable stereo-guided biopsy where we only biopsy the and pick up the calcifications. So now it has been separately given to the pathologist where we segregate the calcifications and section it in such a way that for the pathologist it becomes easier. So here we see how the radiologist, the pathologist, the surgeon, we all act as a single unit and a team where we help each other and learn with each other and help each other's process. Again, this is a wire-guided stereotactic. It's a mammo-guided excision where it was non-palpable. So in mammograph, there was a small lesion which was seen. So in ultrasound, also it was seen. So during surgery, prior to surgery, we do a wire insertion and help the surgeon to do a stereotactic excision. So mammographic screening. So limitation is, as I said, in young females, the sensitivity is lower because of the dense breast or the dense glandular breast. The density can be objectively assessed although, and full field digital mammograms are better than the 2D mammograms are slightly better evaluating dense breasts. And in additional, we can use then ultrasound and MRI. So as here this picture depicts the same, where in the first line of images, we can see the mediolateral and craniocaudal views where the breast is entirely fatty. So any small lesion also can be easily picked up. But the next line of images where we can see maybe of a young female where the breasts are really dense. So it lowers the sensitivity of the mammogram. But in today we have tomosynthesis, which helps us in sectioning these 2D images. And by sectioning this, we can see at every level if there is an abnormality. So technology is improving, every day it's improving. And we see, day by day, we are able to solve the problem at a very low level, or even the challenges which we face are now being overcome with the advances in the technology. So yes, missed cancers are there. 10% of the cancers can still be missed, usually due to the dense breast. As I said, it's because of the reproductive age group. Females, they have dense breasts where we can miss it. Positioning and reading errors, as I said, technologists, they have to be, sometimes the positioning, the nipple might not be in profile, there's no symmetry, or there's no pulling of tissue, retromammary space might not be completely in view. So sometimes because of these errors, there can be positioning errors, we can miss cancers. Reading, that is interpreting errors, is inevitable. Good technique, needless, enough stressed on that. Dedicated reading, as I said again, the radiologist, it's a very cliche, it's a very subspecialized branch where the more mammograms a person sees, a radiologist sees, the more we are able to pick up very subtle, very early lesions, even in a dense breast. So we need to train ourselves in that particular field. Double reading, of course, is help. Now we have computer-aided diagnosis, AI is coming into play. Yes, so mammography screening, false alarm, it does cause anxiety every year. Prior, even while booking the appointment, patients are very anxious. When I am screening a patient, they keep looking at me. They are very anxious because, yes, it does cause a lot of fear in them, even if they so far have not developed any abnormality, but they are very, very fearful of even coming and taking up an appointment and coming for the regular yearly annual screening. And sometimes for something very maybe not sinister also, we keep on streamlining it and we try to do additional procedures because we don't want to miss anything. That is more relevant than doing additional. That is always our aim. Cost is definitely involved, especially in our country. Cost is a big detrimental factor. loss of faith in the screening process, in the sense that, see, here on your women are coming to us, but ultimately in a particular woman, we might not find cancer throughout her life. So sometimes they might feel it has been useless. But what if she had developed abnormality? That is what we are targeting at. So this is what I want to say, is that it's a fine balance. We have to balance out false positive, missed cancer, recall rate, and what ultimately we are trying to do, and detect something at a very early stage through screening, and so that very effective cure can be given with minimum intervention. That is our aim. That's the aim of the early detection, is through screening, that we are able to offer the patient complete cure with minimum interventions. So the National Cancer Institute definitely states, yeah, patients are also anxious because of this radiation dosage, but clearly, as the National Cancer Institute states, that mammograms require small dose of radiation. That is 2 milligray is the mean glandular dose for each mammogram. The risk of harm from this is extremely low. Okay. Repeated mammograms, yes, it has a potential, that is between 50 to 65 years women, it has a potential of 0.002% of causing a fatal cancer. But so this is far lower than the benefits which we get off the screening program. The benefits of mammography, definitely they outweigh the possible harm from the radiation exposure. So coming to the technique, the radiation safe, on that also we take proper measure to reduce the radiation and keep it to the minimal level possible by a good compression, a good technique, so that we avoid, there's no discrepancy, and we avoid additional views or repeat views, not additional, repeat views. Good technology using the latest machine through quality control and quality assurance programs. Overdiagnosis can happen. Some low-grade DCIS might never grow to become killer cancer, but we treat them with surgery and radiotherapy. So, so overdiagnosis and overtreatment can happen, but still it outweighs the risk of missing something. Screening in India, it's a large population-based screening. Is not done going on. It's not happening in the near future. It's more of an opportunistic screening which is happening, because where the patient themselves or the women themselves come and want to get themselves tested. That is what is happening presently in India. And our aim is we should do justice to the woman who's seeking to be tested. That should not be left. We should leave no stone unturned for that. So problems which we face is technology, technique, interpretation, reporting. They are not standardized, audited. There is no follow-up. As we know in our country, if something is normal, people might not turn up for many years. Or they might be very apprehensive, even if something is detected to a very small extent. So these are certain problems we face. Effective assessment and management of screen-detected lesions, not available everywhere. So this is happening more in the metros. In the smaller cities, such advanced technology is not available in field like breast imaging to such an extent. Films which are given to women are often degraded or lost in time and not available for comparison. As I said, comparison is the key for breast imaging. Here we see the technique is wrong there, because the nipple is not in profile in the second image. So we are not able to see a dense lesion which is in the retromammary space. Here again, technique, a faulty technique, where the nipple, this is a craniocaudal and mediolateral views, where the nipple in profile is not seen. So these are the faulty techniques which we should be wary of and guide the technologists. Again, very degraded image, where partly it's obscured, the left side image, it's partly obscured. We are seeing a very heterogeneous it's not a readable image and it's really degraded. Patient might lose it and not bring it in a next follow-up. So this is an example of a reporting where there's a very open-ended statement like mass lesion and suggested follow-up. So BIRADS plays a very big role. It's a global language which we follow, and it's really helpful. And universally, we should try to follow that BIRADS language, where that one staging or one language, gives an idea to everybody who's dealing with that particular patient of what is being said, and they interpret that, right from a radiologist to a pathologist to a surgeon to medical oncologists. Everybody follows the same language. They're able to easily interpret without further explanations. So that's what BIRADS helps us to do. And it's very important we only follow BIRADS language and lexicon. So this is again a report where, the language is, it's misinterpreted, where we are saying grade BIRADS 3 or 4, and then we suggest FNAC. So it has to be single BIRADS which we should follow, because what we are trying to convey should be given in a single line. It's like a diagnosis we are giving, so it has to be singular diagnosis, and they should anybody who deals with the patient next should be able to get a clear picture. Should be no discrepancy. So again, over-reporting also happens in the sense anything which is picked up, any subtle thing also should not be overly be worried. We should not be overly be worried about. For example, in this case, it's a small subtle lesion which is not of much significance, because we have it's very clear there are no other suspicious abnormalities, no associated features that are suspicious. So should we really be following this up? So the answer is a clear no, because patient will become anxious, and we might mention it, but it need not be followed, and accordingly our BIRAD should be guided. So here, so this is a better language which we follow, where we are saying, okay, it's a fibroadenoma, where we say it's a short-term follow-up, and what should be done in a follow-up. So it's a clear stepwise protocol which we should follow, where we give the diagnosis, we say what BIRADS it is, what should be done with it, and what modality also. So these are some missed cancers, unfortunately, where we are the same patient, where we are able to see different patients. On the left, we are able to see in the retromammary space, there's a small lesion. Earlier, it was not seen. Then there is development of that. Similarly, on the right side, there's a large lesion. There's a large interval lesion which is developed. Same here, missed cancers. So unfortunately, because of the faulty techniques or wrong interpretations and so many other factors which we should be wary of, we can miss these findings, which can cost dearly to the patient as well as cost-wise, and the whole system is affected. So confusion and understanding, screening and diagnostic. Screening is more where the person is asymptomatic. We don't even call them patients. The woman who walks in is asymptomatic. We're just trying to rule out any abnormality. Whereas a diagnostic mammogram happens when the woman walks with a complaint. So each has to be dealt in a different approach. So, and we combine all the mammograms. As I said, we compare the mammograms with the previous ones, and based on the requirement, we do a breast ultrasound. Yes, too much irrelevant information also comes up, but again, it depends on the acumen of the radiologist, to stress more on what is relevant and what is irrelevant. We have to filter it out, and we have to always remember the anxiety of the patient. But we have to mention it in our report. Unfortunately, it creates confusion and distress in this Google generation, where anything we mention, women, they do become anxious, and they get stressed out. But that has to be kept at bay, and that's where BIRADS comes to our rescue. And ultimately, that's what we are trying to convey. So that has to be given relevance. So BIRADS is meant for the standardization of reporting, It helps clinicians, pathologists, everybody. We follow this universal language to decide the appropriate course. Set protocol is there, and and for each patient we can custom depending on the necessity, and it's a very complex heterogeneous disease, of course. So we can tailor it according to the requirement of the patient. We can, on each case, it sometimes follows a different approach is needed. So Birads helps us in following a single language, and based on that, then we can take further course of action. But unfortunately, it's often misunderstood, and ambiguous Birads are given in the same report. So mammographic screening, when and how often? In India, we should start screening at the age of 40. Over 40% of our cancers occur in the 40 to 50 age group. The mean surgeon time of tumor growth is shorter in younger women. So the screening between in 40 to 50 age group should be yearly, whereas above 50, we can do screening once in 2 years. And high-risk women like BRCA positive, or women who have relatives who were detected with breast cancer very early, should who have a strong family history, they should have a yearly screening with alternating MRI breast as well. Because with the dense breast, or something where we should not miss something in a young age group, we can do a MRI breast. So ultimately, the conclusion is that screening mammogram, whatever you might call it, it should be definitely the part of a routine checkup, a health check, or cancer screening, whatever name we can call it by, but it should be mandatorily be a part of that. A good technology and technique is quintessential for that. Mammogram is the gold standard. Ultrasound should always be a targeted modality. We should not do ultrasound for every patient. And standard terminology has to be used. As I said, Birads is a universal language that alone should be used by everybody. And a standard reporting format, so that it becomes easy for patients, clinicians to understand. Thank you so much. Thank you.
Thank you so much, ma'am, for the wonderful presentation. Now, I would request the audience, if they have any questions, we can proceed with the same. Okay.
So if anything is there, maybe I can answer in the chat box also later. Thank you.
Sure, ma'am. Thank you so much, ma'am. It was lovely having you with us.
Happy Women's Day.
Happy Women's Day, ma'am. Okay. So moving on with our next keynote speaker, I would like to welcome Dr. Andrew C. Fenn. He is currently working as consultant radiation oncologist, Department of Radiation Oncology in Coveri Cancer Institute, Alvarpet, Chennai, Tamil Nadu, India. We welcome you, sir. Welcome, Dr. Andrew. So we can't hear you.
Hello, am I audible now?
Yes, sir, you're audible now.
So, sorry about that.
Okay, sir, welcome, sir.
I just, can somebody share my screen? I'm having some problem with the laptop. If you have the presentation. Yeah, I'm sorry about that. Some technical problem with my laptop. I was not audible through the laptop, so I've joined through my phone. I'll just, if somebody can share the presentation, I'll just, yeah, or just give me a minute. Like just to wish our women colleagues happy Women's Day. And I'll just be sharing a presentation. In general, breast cancer and cervical cancer are among the commonest cancers seen in women. And as we know, in India, the incidence of breast cancer actually overtook cervical cancer about 2 years ago. Just a minute. Yeah, is my presentation seen?
Yes, sir, it's visible.
Okay. Can we go to the next? Not able to change the slide. 1 minute. Yeah, thank you. So, yeah, this basically is cervical cancer. How I'd like to, the topic given was cervical cancer awareness. And in general, we have, so I just thought I'll go through an overview of cancer of the cervix and go to the next slide. Yeah. So as far as screening is concerned in cervical cancer, it's one of the most important screen detected cancers that we are quite well aware of. So of course, of the 5 cancers that we dealt with, 5 topics that we had dealt with today, almost all were on breast cancer, and we have a small topic here on cervical cancer. Screening, when we look at the US recommendations of the US Preventive Services Task Force, they mentioned that screening should not be done less than 21. Above 21, you should do a pap smear. And if there's if you do a combination along with the HR, that is high risk HPV testing, along with the standard Papillon stain or liquid cytology pap smear, you can do a screening every 5 years. Go on to the next slide, and I'll just talk about about the Indian data. So in India, how we do it is, this is from the FOXI recommendations. You have to divide it as good resource and limited resource. So, and that's something that's unique to our country, where we have it divided according to how the facilities for screening are available. So in a limited resource set, you just have the visual inspection. But in a good resource set as such, you have the HR, HPV testing, as well as, along with cytology, we call as co-testing. And in other things, when you go further, you can have the colposcopy, genotype and genotyping. And of course, the management options accordingly differ between the good resource and the limited resource settings. Go to the next slide. Yeah. So again, the Foxy starts their screen. They recommend the screening at age 25. If you notice, it's different from the US guidelines, which recommended a little bit earlier. That's at 21. And in in general, again, VIA is what is done in a limited resource setting, when most of the time a good resource setting, you go for the HPV testing as well as colposcopy and biopsy accordingly whenever required. Mainly it's liquid cytology and HR-HPV testing. That's what's most commonly used. And when you do the combination, you can probably screen every 5 years. That's the takeaway from the screening guidelines. Can you go to the next slide? Yeah. So this is a big, very busy slide. So I just take something that's very important for when you're dealing with a hysterectomized woman. That's a woman who's undergone hysterectomy for benign disease or for whatever indication. Screening is usually not recommended if we can identify that the cervix has been removed, positively identified either by clinical examination, definitely by, in addition, we may need to do imaging as well. You can go to the next. So again, what I'll just try to, and there's something that is different also for India. We have something called a single visit approach, which is not available in most Western countries, or it's not available in a guideline that you might find from the NHS or somewhere else. So this is something that is very specific to India. You have a see and treat and a screen and treat approach, and it's a criteria for a single visit approach. Screening in cervical cancer is a topic by itself, so I will not take so much of time to just go through, but primarily, again, what I would like to stress is that if you are in a low resource setting, visual inspection by itself is good enough to detect early cancers. And many places in India where you have a rural hospital, they do it via visual inspection as such. Colposcopy, if possible, is good, and if it's available, we use it, but it's probably it's only in a urban or in a semi-urban setup that can be practiced. Next slide, please. Yeah, we go on to vaccination. So cervical cancer is one of the cancers, again, it's screen detected, as well as it's one of the cancers that can be vaccinated against, which is a very which is something very nice to hear. I get many patients in OP who actually ask, can we get vaccinated for cancer? And you can't get vaccinated for cancer. We have not reached that stage yet, but then there are two cancers for which vaccination is available. That's hepatitis B related HCC, as well as cervical cancer. And there are two vaccines that are commonly used or available, Gardasil and Carvarix, otherwise known as HPV4, HPV2, indicating the number of serotypes that are used. Vaccination should start early, ideally prior to the, definitely before the onset of sexual. Can you go back to the previous slide? Yeah. Before the onset of sexual activity. So that is why the vaccination should start by the age of 9 or 10 is what people say, and what is recommended as such. And you have 2 doses. If it's before 15 years, it's only 2 doses, 6 months apart. 15 years and above, you have 3 doses that need to be given. As well, if you have a girl who is less than 15 years, you need an immunocompromised, that is HIV positive or some other immunocompromised state, you would need to give 3 doses, because to improve the vaccination or the antibody response. And HPV4, the dose intervals are slightly different, 0 to 6, and for 2 it is 0, 1, 6. Next slide, please. Yeah, CDC is also a similar recommendation. This was from the previous recommendations was from the IAP. This is CDC also recommends. The vaccination after 26 years is generally not recommended, but then there are trials going on where people are trying to look at whether it helps. Next. Yeah, so this is a paper which was published from long-term data from Sweden. Next slide. So they've shown that the cumulative incidence of cervical cancer is almost definitely more than 50% reduced in patients who had the vaccine, or in women who had the vaccine, and than in those who did not have the vaccine. So the cervical cancer vaccine works, but it's not a complete guarantee against cervical cancer, and screening has to continue. Even if you are vaccinated, screening has to continue as per guidelines or as per each country's recommendations. Next slide. Yeah, so this is something which is relevant for our country. What is the difference between 1 dose of vaccine and 2 or 3 doses? Next slide. Can we get away with just single dose? This might be something that is relevant for us because the cost of the vaccine is a little high, and recommending it to the general population may result in a lot of extra cost. So what we find is actually the antibody response rate for 1 vaccine or 2 or 3 doses is almost the same, and in general the single dose of vaccine will provide, at least antibody detection wise, it provides similar protection, but then we don't have the data to say that we don't have the long-term data in India as such to provide say the incidence of cancer wise, but at least this antibody wise, it's a single dose is as good. Next slide. Yeah, so when we go to this staging of cervical cancer, it has undergone recently, it's gone for a real change as such. So you have 2009 FIGO, which is what most of us would have been used to as we were training or when we practiced, and most of the trials are based on the 2009 FIGO. So most of the data that we have, the management decisions, everything is based on the 2009 FIGO. And 2018 FIGO has just come out. It's not just come out, it's come 3 years ago, but still we are getting used to using it. And it clarified certain things in stage 1A, where the 7 millimeter width, that part had just been removed, and you just have the depth that is mentioned. And when you have come to the 1B staging, you didn't have a 1B3, but in the 2018, the new FIGO, we have a 1B1, 1B2, and a 1B3. The 4 centimeter has been changed to a less than 2, 2 to 4, and a greater than 4 centimeters. So these, I'm not highlighting the entire staging in FIGO. I'm just highlighting the changes. And the other thing was you have something called the 3C1 and a 3C2. That is, 3C1 is the pelvic node and 3C2 is a parietic node. So this was something that we all knew before itself, that the nodes had something to do and they do affect prognosis. And in general, even though a parietic node was mentioned as a 4B in 2009 FIGO, we used to treat it radically. And that has been brought out in the new staging where it comes out as a 3C2. So it's generally, it's not to be treated like a metastatic disease, but it is to be treated like a locally advanced disease. And the pelvic lymph node, we also knew had a poorer prognosis but then there was no way of mentioning a pelvic lymph node in the old staging. It would be just, it would go off as either a 3B or something as per the local staging. So if there wouldn't be a way to detect, mention a 3C1 as such. Next slide, please. And this is just to compare it with the T staging. If you notice, this is based on the old FIGO only, but then we're talking about the TNM staging here, and the TNM staging grossly, or if you take an overall look at it, the T staging corresponds to the FIGO staging as such. That is the T1A, T1B, and the T2 and the T2A, it corresponds to stage 2, and the T3 corresponds to stage 3. So it's not that much different. Of course, you have the N and the M, which is an additional thing. So there is a, so when you have two stagings, generally in practice, we'll go by FIGO. But then if you have to look at data and you have to compare data with other places, you might need to adjust and use a TNM as well. Next. Yeah, we can skip this slide. It's just that pictorial description of the same. How do we go get to the staging? If what is usually recommended, pelvic examination, biopsy is mandatory, colposcopy if needed. MRI is definitely a requirement for a cervical cancer for the local staging. If you look at the pelvic examination, what is better? Is an examination under anesthesia better? Definitely it would add information, but may not be possible in all cases. I usually do it when it's a difficult biopsy in the clinic. We usually go for an examination under anesthesia and then biopsy in the theater. At that time, we would also examine. That would be the situation which would happen in the clinic. But in a busy OPD with a lot of patients, you may not be able to do EUA for every case that you see. Endovaginal transrectal ultrasound is optional. Case by case, you can decide. If any findings are detected on imaging which show that there's a rectal or a bladder infiltration, then a cystoscopy or a rectoscopy bar sigmoidoscopy is mandatory to rule out mucosal involvement, and you may need to do a biopsy to prove the same. Next. Yeah, I forgot to mention one thing about the lymph node staging here. So what I mentioned in the imaging about is about the this thing, the primary staging. The lymph node staging in general, a CT scan is better, and now we have PET CT. So PET CT is not recommended as part of the staging for a carcinoma cervix, but it is an important part of the staging and important investigation that should be done, especially when chemoradiation is being planned as the primary modality of treatment, mainly to target the pelvic lymph nodes. If there's FDG uptake, it helps us in our radiation planning to actually give a higher dose there. And this has shown better outcomes as far as the pelvic control is concerned, the lymph node control. Yeah, so I'll just go stage wise. Previous slide, please. So I'll just go stage wise. And this is from our, this is just basic ICMR guidelines for customer cervix management. I don't want to go into very detailed managements because sometimes it's very straightforward. And here we have something called a 1A1, which is micro-invasive. The options are surgical, close observation if there's no LVSI and if the margins were clear. And there is a option of brachytherapy. That is, if the patient is inoperable. But usually in such a case, we would not do brachytherapy. We would just go for observation as such. That's how we do it in practice. The modified radical hysterectomy and tracheotomy with lymph node is especially needed if you have an LVSI positive. So, and this is also this will also enable fertility to be preserved. Go on to the next slide. 1A2, again, similar treatment, except that extrafacial hysterectomy is off the list now. We just need to go for pelvic lymphadenectomy. Some practitioners would question this management, and they would just say that if the LVSI is negative, probably we can do observation or just hysterectomy as such here. I'm not here to argue on that, but definitely some form of treatment is required. Again, brachytherapy and external beam radiation, I would think is more unnecessary. And we could probably just go with a radical cone with a pelvic lymphadenectomy. That would be the ideal option. That's what I would do. Pelvic lymph nodes, again, with when this paper was being developed, SLNB techniques were not common in carcinoma cervix. What could be done is, instead of pelvic lymphadenectomy, an SLNB could also be done in such a scenario. I think my surgical colleagues would probably be better poised to answer that, but I'll go on to the next slide. Now, when we come to invasive cancer, that is 1B1, where the lesions are seen, and then the options become more clear. And if the size of the lesion is less than 2 or less than 4 centimeters, rather, surgery is a definite option. Radical radiation with brachytherapy is an alternative option when you have a medically inoperable patient. But in a less than 4 centimeter situation, it's always better, and there's no vaginal involvement, and there's no if there's no parametrial involvement, we should just go for a surgical option. Next slide. Yeah, when the size goes above 4 centimeters, as per this slide, I would prefer to go that, and you can see that in the guideline also they put chemoradiation a little above the surgical option. And the reason is simple: more than 4 centimeters, the chance of lymph node metastasis is quite high. Definitely, you're going to end up post-op with chemoradiation post surgery. So it's better to go with a single modality rather than dual modality. So it would be preferable to plan for a chemoradiation protocol when the size of the tumor is more than 4 centimeters. And the reason I would say avoid post-op radiation is simple. It is tougher to give post-op chemoradiation than it is to give it as a radical option. And the main reason for this is simply because if you have a nascent abdomen which has not been been operated upon, the bowels move freely and they're not stuck in a place. There's no adhesions. So the dose of radiotherapy that a bowel receives today is not the same bowel which receives it tomorrow. So the bowel keeps moving. So the chance of toxicity due to bowel toxicity due to radiotherapy comes down. So patients tolerate the treatment much better in a radical situation rather than in a post-op situation. So if preferable, it's always best to do radical chemoradiation in a situation where the size of the tumor is more than 4 centimeters. Next slide. And this, now that we've dealt with most of the surgical, that is options, what are the indications for post-op radiation? Like I already mentioned, positive nodes is one of the indications for a chemoradiation, and there are high risk factors as well as intermediate risk factors. In general, the high risk factors are positive parametrial, positive margin, or positive node. You have to give adjuvant radiation with the concomitant chemotherapy. Usually it's platinum based, either cisplatin, mostly cisplatin rather. And then you have the intermediate risk, where if the size of the tumor is either 4 centimeters, again here if you notice they've made the T greater than 4 as one of the intermediate risk factors. And I would say that a tumor that's more than 4 centimeters should not have been operated upon, but then things may factors may change, patient wise, MDT decisions may change. So if it's discussed in MDT and if everyone feels the same, yes, surgical approach is also good. But if you notice it's any two, and if the 4 centimeters is already there, getting the other two is not very difficult. Deep stromal invasion, LVSI will automatically be there. So I in general use this one, even if one of these factors is there, I would go for adjuvant pelvic radiation, and I would not wait for the second factor. But I may not add chemo, but definitely adjuvant RT would be there in one of the is part of the treatment protocol. And low risk, when you don't have any of these features, then definitely you can go for observation. Next slide. Yeah, so this is pretty straightforward. 2B and 3, you need to go only for there's only radical chemoradiation. Once the parametry are involved, whether medially or up to the pelvic side wall, there's only an option of radiation. Of course, the paranoid outtake is involved. We will go with the induction chemo protocol first, and then go for a extended field radiotherapy to the paralytics. Next slide. Yeah, so this is what I wanted to just highlight this. Usually in many centers or in many situations as such, brachytherapy is not available, or it's not preferred. The patient doesn't prefer it, the doctor doesn't prefer it, and the hospital itself doesn't prefer it. Means the facility itself is not there, and you have to outsource that. So this was a trial from Mexico where they've done a phase 3 study. They've included 1B2, that is anything that is locally advanced or anything more, either vagina is involved or a size more than 4 centimeter, along with 2B, that is parametrial medial infiltration, not up to pelvic side wall. So they've done this, they've done chemoradiation, and of course their protocol was slightly different. They used gemcitabine and cisplatin. In general, in India, we use only weekly cisplatin. Along with, and once chemoradiation was completed, if the patient received, the patient would be assessed, and they would go for one of two treatments. Either they would go for brachytherapy, or they would go for a radical hysterectomy in a month's time, after a month, or rather 6 weeks post radiation. Next slide. The results were quite surprising. They had actually postulated that a radical hysterectomy would be superior to EBR, to brachytherapy, but they could not prove that. And in fact, they showed that it's not superior, but that it's feasible. In other words, it's almost equivalent. So one of the things that take away from this is that a radical hysterectomy can replace brachytherapy after a 1B, for a 1B2 to 2B, say cervix post chemoradiation. And this was one thing, this was one of the evidence for that. I would just like to mention that a hospital here in Chennai, that is Roy Pattar Hospital, is actually doing a trial right now, a randomized phase 3 trial to identify whether radical hysterectomy can replace brachytherapy for a CS cervix locally advanced that has completely responded to chemoradiation. Next slide. Stage 4 is palliation. So whatever, you can do palliative radiation, palliative chemo, bevacizumab based therapies, and of course you can go for a palliative surgery, also palliative bypass, symptomatic support. So it's individualized based on an MDT, or a separate consultant can also take a call. What the patient wants, what the family wants. Sometimes if it's very advanced, we just say best supported care. Next slide. So this is, I just wanted to put a patient just to tell about how I treated a patient. So this is a 42-year-old lady. And of course, I mentioned about PET scan and how PET scan actually took me into a pitfall here. So this is a 42-year-old lady who presented with postmenopausal vaginal bleeding PV and growth in the cervix. It's about involved the upper vagina, bilateral para, the rectal mucosa was free. So this would clinically, the primary staging was stage 3B. We need to do imaging. So we did a PET scan. Of course, biopsy was done, squamous cell carcinoma. So PET scan and MRI was done with the local pelvis as well as PET CT whole body. Fortunately, the PET scan showed a pelvic lymph node, but it also showed some axillary lymph nodes. So this actually put the axillary lymph nodes were not expected. So, but the uptake was quite significant. I don't have the images here. I'm sorry, I could not put it up in the hurry that I had for this presentation. But can you go to the next slide? So we just took this patient to the MDT as usual because it was an unusual finding. So we planned for a biopsy from the axillary lymph node. Next slide, please. So the axillary lymph node came back as reactive lymphadenitis. So this is the problem with the PET scan. It can identify certain nodes and certain areas which have uptake, but we will not be able to know without doing a biopsy. Of course, the pelvic lymph node was quite significant and quite enlarged, so we took that as positive. But then this axillary lymph node was present, but the uptake was quite high. So we took it for a biopsy. The biopsy came back as reactive lymphadenitis, and So so the patient was planned for a radical chemoradiation protocol. I think the screen has gone. I think somebody can help me with that. Okay. I'll just take it to the last few slides. I'll just keep talking. So we underwent, this patient underwent chemoradiation, pelvis, and I gave a SIB approach to the lymph node. So that is, we give a slightly higher dose to the lymph node. So if you can see in this picture, I've actually, the entire pelvis has got about 50 gray, and the lymph node, which is seen in the left iliac region, is getting a slightly higher dose. So 50 gray and 55 gray to the lymph node. You go to the next slide. Yeah, this is the same thing showing the lymph node when showing the 55 gray volume. So in that you can see that the pelvis is not getting 55 gray, only the node and the region is getting a very high dose. So this was not possible in the earlier era with the 3D conformal therapy, but it's quite possible with our IMRT and rapid arc era, where we're able to dose paint and give a higher dose to regions where we would like to have higher dose. And this would actually improve outcomes as such in a node and it would prevent a nodal recurrence in that area, because we can give almost 60 gray equivalent to that region. And when you combine chemotherapy, it would actually be a little higher, may come up to about 64. And so that's why we are able to achieve good local control rates. Next slide. Yeah, so post-therapy, clinical and radiological response was there at 3 months, and patient came for their 1-year follow-up recently. At that time also, the clinical and radiological response was good. So we are continuing to follow up. Hopefully she does well. Go to the next slide. I'm come to the end of my, almost to the end of my presentation. So I've just run through cancer cervix, and now we have some recent advances, just 2 slides. I'm just wrapping up here. So in radiotherapy, the main recent advances is image-guided brachytherapy. It's already come, it's already being practiced in many places, but it's not widely practiced. It should be widely practiced. Hopefully it goes, I have not practiced image-guided brachytherapy, but I know many of my colleagues who do. So very soon we'll probably be practicing in maybe another 5 to 10 years. Hopefully we'll be doing that. And there are some neurosensitizing drugs which are on trial for along to be used along with radiation. That is immunotherapy. I think Madam had already Anita Madam has spoken about immunotherapy in breast, and immunotherapy in cancer cervix is also in the pipeline. It's already here. It's being used, especially in advanced cancer stages. But this is considering as along with chemo, along with radiation in the radical setting, and definitely it's going to come up. And DNA damage response inhibitors, that's also another class of drugs which will be used along with radiation. So soon to be introduced, all around a trial right now. Next slide. Come to medical oncology, or rather in general we call cancer vaccines. So this is not a vaccination against HPV, the causative organism, but it's a vaccine against the cancer. So you have certain cancer antigens that are taken and a vaccine is produced against them. And these are called therapeutic vaccines as such. They are still in the trials and they're showing good response. Once a patient is diagnosed with a cancer cervix, they usually get the cancer vaccine, and probably they also undergo standard treatment, and the response rates are looked at. So this is a vaccination once the cancer has been diagnosed. So it's otherwise called not a preventive vaccine, but a therapeutic vaccine. Of course, we have immunotherapy, which is already mentioned. Immunotherapy is there everywhere now. It's not. It started with melanoma, and now then it went to lung, and then we have urothelial, and now we have it in breast. And it's of course there in cancer cervix. So immunotherapy is here to stay, and it's almost every site that we can think of in the body is being covered, and it will come. And already it's there in advanced settings, but whether it comes into the lines much earlier, that is in a concurrent radiation setting, we are yet to see that. Adoptive T cell therapy is when a T cell is trained to attack the cancer cell. So this is then reintroduced into the body. So it's under trial, and hopefully we see good results. Tumor targeted antibodies are again and antibody drug conjugates, something similar to what we have seen in breast, that is trastuzumab emtansine, TDM1. Similar to that, we have similar drug combinations being developed for cancer cervix, where a cancer cervix antigen or an is tagged, or an antibody is tagged to a cytotoxic drug, and then this is introduced into the patient's body, and it definitely shows better response rates and less toxicity, which is very important for a cancer patient in advanced stage. This I'd like to end my talk, and I thank the organizers for this opportunity, and I again apologize for the technical issues I had with my laptop. So thank you. If there are any questions, I'm happy to take.
Thank you so much, sir, for the wonderful session. Any questions from the audience? Can I get any questions from the audience? Okay. Okay, thank you so much, sir, for taking out time to be with us here and sharing such information with us. I would request all the participants to please turn on their cameras for the photo session. Kindly, all of you, please turn on your cameras. I again request all the participants to please turn on their cameras so that we can proceed with the photography session. I think we have a question from one of the participants, Abhivyakt Vyas. Okay. Thank you all for joining in us in this webinar session. In the end, after all this presentation, I think it will be better to conclude it with a quoted line of Robin Roberts, that it's about focusing on the fight and not the fright. So on behalf of International Association of Oncology, I heartily thank all the delegates and students who have joined today. Thank you all for participating in our webinar. Stay tuned with us for more updates regarding the International Association of Oncology webinar and conferences. And you can also download your e-certificates from our IAO dashboard. Thank you so much, everyone.
Thank you.
Thank you so much, sir.